Hey everyone, welcome back. Today's explainer goes straight to the pathophysiology of a condition that often develops without so much as a whisper, but man, it can escalate into an acute clinical emergency in a matter of seconds. We are unpacking the exact mechanics behind deep vein thrombosis and thrombus formation. And look, instead of just giving you a broad, generalized overview, we're going to literally dive right into the biochemical cascade, the hemodynamic shifts, and the mechanical failures that turn a localized clotting event into a full-blown systemic crisis. So, get ready because we're breaking down exactly how this happens, step by step.
All right, let's kick things off with Section 1, the silent threat, a sudden strike.
To really wrap our heads around the impact of this condition, we actually shouldn't start in a microscopic lab. We need to look at the initial clinical presentation. I want you to picture a scenario, one that honestly unfolds for thousands of patients every single year, often with literally zero prior warning. Imagine a middle-aged man standing up after a really prolonged period of immobility. Maybe he just got off a massive intercontinental flight, or maybe he's been working a 12-hour shift at his desk. Suddenly, he winces. He reaches down and clutches his calf in sharp, highly localized pain. He's uncomfortable, he's slightly breathless, and he's clearly visibly distressed. If you were to do a clinical examination of that leg, you'd see the calf is abnormally swollen, the skin is stretched incredibly tight, and the underlying muscle, it feels tense and indurated. It's a super sudden, acute presentation that immediately begs the physiological question, what in the world has just changed beneath the surface?
Well, what we are witnessing here is the classic clinical presentation of deep vein thrombosis, or DVT. A DVT happens when a thrombus, a clot, forms within the deep venous system, which is most commonly going to happen in the lower extremities. Now, as you probably know, these deep veins are mainly responsible for venous return, right? They're pushing that deoxygenated blood all the way back up toward the right atrium of the heart. So when a thrombus forms down there, it's not just acting as some partial occlusion. It fundamentally disrupts one of the body's absolutely essential hemodynamic pathways. The danger isn't just the local blockage, it's the massive alteration in venous pressure and the huge systemic risk that this obstruction throws at the entire circulatory loop.
Moving right along to Section 2, how a clot forms, the micro journey.
Okay, let's really dive into this. Let's shift our perspective, move past the dermal and muscular layers, and go straight into the lumen of the deep vein itself to see this biological cascade in action. Normally, you'd see a nice, healthy hemodynamic state, erythrocytes and plasma just flowing efficiently. But as we approach a damaged or compromised section of the vessel endothelium, the whole biochemical environment radically shifts. This process generally follows a really precise four-step physiological cascade. Step 1 is endothelial injury. Whether it's from microtrauma, a recent surgery, or even chronic inflammation, you get a tiny tear in the smooth inner lining of the vein, which exposes the subendothelial collagen underneath. Step 2 is venous stasis. Because of immobility or maybe valvular dysfunction, the blood flow gets incredibly sluggish. It begins to pool, and that drastically increases the contact time between the blood elements and the damaged vessel wall. Then step 3 kicks in, platelet aggregation. That exposed collagen we talked about, it triggers an immediate local alarm. Platelets rush to the site, they literally undergo a structural change to become sticky, and they adhere right to that injured wall, sending out biochemical signals to recruit even more platelets. Finally, we hit step 4, fibrin mesh formation. That initial platelet plug activates the body's super complex coagulation cascade. This multi-step enzymatic pathway ends up converting circulating fibrinogen into cross-linked fibrin. Think of this like a dense structural protein net that weaves through the platelets, totally stabilizing the clot. And as it hardens, it starts catching passing red blood cells, progressively enlarging that thrombus until it really starts to occlude the vessel lumen.
Now, what's really fascinating and frankly a bit alarming is this concept of hypercoagulability. It's the third pillar of Virchow's Triad. You can basically think of this as the body's hemostatic system being locked in an upregulated state. It's in overdrive. This hypercoagulability can be provoked by quite a few distinct factors. Sometimes it's a hereditary genetic mutation, like factor V Leiden or a prothrombin gene mutation, which inherently alters the blood's normal threshold for clotting. But in other cases, it's acquired. It can be triggered by specific medical interventions. Think major orthopedic surgeries, using oral contraceptives, active malignancies, or even just systemic inflammatory states. When you take this hypercoagulable state and combine it with the sluggish venous stasis and the endothelial damage we just walked through, well, the hemostatic balance is totally destroyed. It practically guarantees that the cross-linked fibrin is going to keep aggressively trapping those passing erythrocytes. This rapidly expands the thrombus way beyond just a simple localized repair job and turns it into a full-blown pathological obstruction.
Which brings us to Section 3, spotting the symptoms, surface warnings.
All right, let's zoom back out from that microscopic view, because while this thrombus expansion is happening deep down in the venous system, the localized physiological consequences absolutely show up on the surface. And knowing exactly what these clinical signs look like in everyday practice, it's literally urgent. Since that deep vein is obstructed, venous return is severely compromised, which forces blood to pool distally. This kicks off a highly specific set of warning signs. For starters, you'll see a noticeably swollen calf, and it's typically unilateral, just on one side. That edema is a direct result of localized inflammation and venous hypertension. The hydrostatic pressure shoots way up and forces fluid right out of the capillaries and into the surrounding tissues. You'll also notice the skin exhibits distinct erythema or redness, and it's actually going to radiate warmth when you palpate it. Those are your classic markers of the inflammatory cascade working in overdrive. On top of that, there's marked tenderness. Patients often describe it as a deep, cramping ache that gets way worse during ambulation or active dorsiflexion of the foot. Oh, and you might also spot some engorged superficial veins. That's because the pressurized blood is essentially looking for a detour. It's forced into collateral surface vessels, searching for any alternate pathway to bypass the deep obstruction. Recognizing these specific physiological signs is absolutely crucial.
Okay, on to Section 4, the deadly complication, the breaking point.
So the crucial point here is that while a stationary thrombus causes localized pain and severe edema, the true systemic crisis hits if that clot loses its structural integrity. If hemodynamic pressure builds up too much against the obstruction, or if the thrombus is just inherently unstable, a piece can actually shear off. It becomes what we call an embolus. This free-floating clot merges onto the venous return highway, traveling superiorly right up through the inferior vena cava. It enters the right atrium, passes straight through the right ventricle, and gets pumped directly into the pulmonary arterial circulation. And here's where the mechanical crisis happens. Because those pulmonary vessels aggressively narrow, the embolus inevitably wedges into a smaller artery, causing a pulmonary embolism, or PE. By blocking pulmonary perfusion, the PE instantly creates a massive ventilation-perfusion mismatch. The lung tissue is getting oxygen from the airway, sure, but there's literally no blood arriving to absorb it. This causes a precipitous drop in systemic oxygenation and acute right ventricular strain because the heart is suddenly trying to pump against a totally blocked system. It can escalate to fatal cardiovascular collapse in minutes. Remember that breathless feeling our patient in the opening scenario had? That right there is the absolute hallmark symptom of an impending or active pulmonary embolism. It's the ultimate warning sign that a localized leg issue has just morphed into a life-threatening cardiopulmonary event.
All right, let's all take a deep breath and move to Section 5, Treatment and Recovery, Restoring Flow.
Okay, as severe as the physiopathophysiciology of a pulmonary embolism is, the good news is that modern clinical interventions offer highly precise solutions to halt this cascade. Medical interventions conquer the clot systematically. In hour 1 of acute treatment, anticoagulant medications, things like heparin or direct oral anticoagulants, are introduced into the bloodstream. Now, it's really important to note, these agents do not actually dissolve the existing clot. No, they just inhibit the coagulation cascade. They act like a chemical roadblock to prevent further fibrin cross-linking and stop the thrombus from growing any larger. Then, over days 1 through 7, with the expansion finally stopped, the body's own natural fibrinolytic system finally gets a chance to step up. Plasmin enzymes go to work, gradually cleaving those fibrin strands, slowly degrading and shrinking the clot over time. Moving into weeks 2 through 6, patients will often use compression therapy. Specialized graduated compression stockings physically support the venous walls. This reduces the vessel diameter, which in turn increases venous blood velocity and fights off that sluggish stasis. And by month 1 and beyond, the clinical focus shifts heavily toward early mobilization. Ambulation is the ultimate long-term prevention strategy. Walking actively engages the calf muscle pump, physically squeezing those deep veins to restore optimal, healthy venous return.
And this brings us to the most powerful, absolutely crucial takeaway from our source material today. Early diagnosis saves lives. I know, it sounds a bit elementary, right? But it is literally the foundational truth of vascular medicine. Intervening during that early localized DVT phase, before the thrombus has a chance to destabilize and embolize to the pulmonary circuit, completely changes the game. It turns a potential cardiopulmonary collapse into a highly manageable condition. Recognizing those localized inflammatory and hydrostatic signs early on is exactly what gives clinicians the window to deploy anticoagulation, restore unhindered blood flow, and ultimately preserve systemic hemodynamics.
So, I want to leave you with a question to really think about. Would you recognize the silent signs of DVT? If you, or maybe a patient, suddenly presented with unilateral edema, localized warmth, and a deep aching calf, would you instantly recognize the underlying pathophysiology at play? I really hope this explainer has deepened your understanding of the mechanics behind these symptoms and empowered you to spot an emerging vascular crisis before it's too late. The human circulatory loop is an incredibly intricate, amazing system, and understanding its vulnerabilities is honestly the key to maintaining it. Thanks so much for diving into the clinical details with me today. Make sure you keep those legs moving, and I'll catch you on the next explainer.